Okay, so first I wanted to thank a few people. So Michelle, Ellie, and Ashley have been responsible for arranging everything. So thanks to them for sending out all the invitations and setting everything up. Also, I wanted to acknowledge members of my clinical team, research team. I see if you could.
No.
Sorry. Members of the clinical team, I see Tracy, Diana, and Lindsay, if you could stand up. So some of you, they're the ones that if you're in a clinical study or trying to get in a clinical study, they're the ones that are helping you navigate that, and Tracy will talk more about that experience. I also see some of the people from my lab who do the research that leads to the new drugs, so if they could stand as well. Okay, so this is going to be just an update on treatment, so we can talk about research things or whatever at the end, but this is kind of more straightforward, keeping with the day of learning, teaching you about your disease. So the things we'll talk about a little bit about just background, definition, a little bit about the biology, although mostly just introducing what Chris is going to talk about. And basically one of the messages I hope you take away from today is mutation, mutation, mutation. So knowing what's wrong in your tumor is very critical to being able to treat you in the best possible way. And fortunately we have world-class, through Dr. Corliss testing here, but a lot of patients, probably 90% of patients with just in the United States don't know what the mutation testing is, and that leads to them not receiving always the optimal care. We'll talk about the role of surgery and what we can sometimes do if your tumor is too big to be removed surgically. There's some things we can do. If we remove it successfully, consideration of should we give you something after your surgery to keep it from coming back. That's called adjuvant therapy, so we'll talk about that. And then in cases where the tumor is spread to distant spots from where it started, we'll talk about how that's treated, both the first-line treatment and then what happens if the first-line treatment, which is Gleevec or imatinib, if that doesn't work, what do we do next? We'll explain or talk a little bit about why that happens, how we overcome it, and that sometimes will lead into more of what Chris is going to talk about and also what Tracy is going to talk about. So, a lot of people probably know this, but I guess we should start with what is a GI stromal tumor or a GIST? So this is a type of cancer that if you would have asked this question at the time that Mark was born, or even until he was 3 years old, there would not have been a definition of this because there was no recognition prior to the year 2000 that there was a thing called GIST. So it used to be lumped in with something called leiomyoma, or it was lumped in with leiomyosarcoma. And the reason for that is that, as Chris will tell you, mostly when we diagnose cancers, we're using the best technology of the 1800s, which is a light microscope. And so we're looking at things and saying that these things look alike or they look different and giving them names. But as we've come to realize, not everything that looks the same is the same. So not everything with 4 legs is a dog, or even a dog versus a wolf is not the same thing, even though they look pretty much the same. So there are differences that we can draw out. So prior to the year 2000, we didn't actually even realize that there was something called a GIST. But when Mark was about 1 year old, there was a very important paper published by a group from Japan. And so they first identified some important things that we still use today. One is they identified for the first time that there was something called the KIT protein, and we'll talk a little bit more about that, that was expressed in these types of cells, and that you could do a pathology test and show whether the KIT protein was there or not, and that would allow you to say that, aha, there's something new that we're going to call GIST, and these other things that it looks like, we're going to call them something different. And more importantly, for how the story went down, not just in terms of diagnosis, but in terms of treatment, they described for the first time that there were mutations of the KIT gene, which led to activation. And as we'll talk about, the KIT gene is turned on and is the power supply for about 70% of GIST, and we'll talk about the other 30%, and Dr. Corliss will talk a little bit more about that. But what we learned from this really original paper was that these mutations cause the enzyme to be activated, which means really the power source for the cancer was turned on abnormally, in these cells, and we'll talk a little bit more about that. So this immediately allowed us to test for KIT expression. So what you're seeing on this slide is you can take an antibody which recognizes the protein, and then you can do an enzyme reaction that turns where the antibody and the protein are brown. So when you're looking at this, all of the tumor is brown, and the normal tissue at the top is white, and so we can say that this tumor expresses the KIT protein, and most tumors do not. So this allowed us to have a uniform and now universal way that we could look at something and say, this is a GIST, or this is not a GIST. Prior to this time, we did not have that. We also realized that even though we had a suspicion that there might be something going on with stomach tumors, that they weren't all the same, we then realized using KIT staining that these GIST tumors could arise at other locations. It had also provided a clue to where these tumors were coming from. So most stomach cancers or colon cancers start on the lining cells. They're called adenocarcinomas. They're from the lining cells. But GIST actually arise in the wall of the stomach or gut because they arise from the pacemaker cells. So a long time ago, someone who actually won the Nobel Prize for Anatomy and Physiology, Santiago Ramon Cajal, had described these cells, which have come to be called the interstitial cells of Cajal. And these are the pacemaker cells that allows the stomach to grind things up and to push things basically from one end to the other without kind of going sideways or backwards. And it turns out that GIST cells arise from these pacemaker cells, which is why they act so unique and different from most cancers of the GI tract, which arise from lining cells. So armed with this ability to diagnose GIST, and Dr. Corliss will talk more about this, we realized that the most common site for GIST to arise was the stomach in about 70% of patients. The next most common site was the small intestine and 5% in the colon, but there's also oddball sites like the esophagus, the rectum, the appendix, the gallbladder, in which patients can occasionally have GIST arise from. So these things arise as a mass, and I think Dr. Corliss has the same picture because I got it from him, but his is turned sideways. So basically this is showing a GIST, and this is the stomach that's been cut open after an operation, so part of the stomach's been removed, and the tumor is basically this part. It's been cut in half, so it's kind of been filleted open. And you can see in the center of it, this kind of looks like blood, and that's because the tumor outgrew some of its blood supply, so it actually kind of hemorrhaged internally. So this is 5 centimeters, which is sort of moderate size. They can be smaller, or they can be much larger. So nowadays we say GIST is a type of cancer or sarcoma that arises in the gut, and we now realize that this is completely different than all other types of cancer and needs to be approached completely differently. This likely arises from these interstitial cells of Cajal, which are the pacemaker cells, and again it gives them some unusual properties not seen in other cancers. Most commonly they arise in the stomach, but it can be small bowel or large bowel. And you know, when we first got into this business 2000, since there was no definition of GIST prior to 2000, we actually didn't know how many people with GIST there were in the United States. We were trying to do a clinical study, and we thought there might be only 300 people in the United States that had GIST. But it turns out that it's more common than that, although it's rather uncommon. So there's about 5,000 to 6,000 new cases per year, which kind of puts it in the same frequency as Hodgkin's disease or CML or a few other diseases. So uncommon, but not that rare. And again, part of the story was that prior to the year 2000, not only did we not know how to diagnose this, we didn't actually have any treatments that work. So how do people present? Sometimes we find them just by routine accident. So you're having some stomach pain or not. Somebody looks in your stomach because they think you might have an ulcer, and they may find a very small tumor which you didn't even know that you had, or you may go to emergency room because you have a kidney stone and they do a CT scan and they find something that they see on the scan which had nothing to do with your kidney stone. If the tumors are bigger, then of course they can cause symptoms, and the kind of symptoms depend on where the tumor is and how large it is. So you might just feel like something's not quite right, or the tumors, if they're larger, can bleed, and so you may become anemic, or you may have signs of external blood loss, so you can see blood that you've thrown up or blood in your stool. You can be anemic if you're bleeding, and it can just produce nonspecific symptoms. So a stomach, kind of important for eating. If you have a tumor there that's taking up space, you may lose your appetite, may lose weight. That can make you tired, and so you can have sort of nonspecific complaints. Or sometimes people present with sort of a surgical emergency. The tumor actually ruptures or has a big bleed, and so patients show up in an emergency room without any knowledge they have cancer, and all of a sudden they're going to an emergency operation because of what's going on. Now, Dr. Corliss will talk about this, but again, going back to my message of mutation, 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 that's our drug target. And so most GIST, about 86% of them or so, have a mutation. So we started off knowing about the KIT protein, which is over here, and there's different locations called exons, which is a location in the gene where it could be mutated. And we'll talk a little bit more about that, but depending upon the type of mutation, that can affect what dose you should be on. Or some mutations over here, like in PDGFRA, they do not even respond at all to our conventional treatments, and that's why we're doing clinical studies to understand them, or how to understand how to better treat them. So there are a lot of different mutations, but you'll notice that all of these things don't add up to 100%, which means that there are some tumors that don't have KIT or PDGFRA mutations, which we're increasingly recognizing, and now using more sophisticated testing like those that developed by Dr. Corliss or that by the future Dr. Bannon in the back of the room, one of my graduate students, we can probably get up to about 98% of GIST. We can figure out what caused them, but there's still 1 or 2% of the pie that we can't figure out what caused the tumor, but we're still working on that. So we talked about this KIT thing. So what is it? So KIT is a protein. It sits both inside the cell and outside the cell. So in this is sort of the wall of the cell. This is the outside world of the cell. This is the inside world of the cell. So KIT has two functions. One is it can bind a hormone, that's on the outside, and on the inside it has an enzyme activity, which is sort of the power source. So normally the way KIT works in a non-cancer cell is it just sits there doing nothing, so it's not a problem. However, KIT can do things that are useful. So under appropriate circumstances, if your body makes a hormone called KIT ligand, then it can act sort of like a glue that brings two of these KIT molecules together. And when they're in a close approximation, then the enzyme activity becomes activated and it sends signaling, and so that causes cells to grow. So there are certain kinds of cells like pigment cells or bone marrow cells that depend upon the signaling, but it's normally regulated by whether the hormone is present or not. In the case of GIST with KIT mutations, the protein becomes activated without the hormone being present. So if this is the enzyme power source for the cell, instead of being sometimes on, sometimes off, it becomes always on. And that's really the driver of the tumor, and our goal of our therapy is to turn off that power supply. Now, it turns out, as I've sort of alluded to, that we started off with knowing that GIST was one thing that had KIT mutations. Now we know GIST is at least 20 different diseases, some more closely related to others. So we can look at KIT mutations, we can look at PDGFRA mutations, we can look at other mutations. All of these tumors might need a different therapeutic approach. So the drug or the treatment that we would apply can vary. That's why we need to know what you have, and Dr. Corliss will talk more about this, in particular how we do the testing that results in this knowledge that allows us to figure out where you fit in this table and then go forward with therapy. So again, mutation, mutation, mutation. So why is it important? Well, this will help inform the decision whether taking Gleevec for as long as 3 years or maybe for the rest of your life after surgery will help you or not. Why take something that's not going to help you, that has some side effects, that is expensive, and if it's not going to help you, why take it at all? So knowing that mutation is important for that. In some circumstances, although this is only a couple % of the pie, you may have inherited the susceptibility to the GIST from your parents, which means that your brothers and sisters, your parents, and your children could be potentially at risk for getting GIST as well. in that system or in that situation, we can test to determine who in your family might be affected, and there's effective screening ways that could prevent them from getting GIST or other tumors. Knowing what type of mutation can determine what dose of Gleevec you should be taking, whether it's 400 a day or 800 a day. And also, and Tracy will talk more about this, increasingly because GIST is diverse and different treatments work different or the same, in order to go into an experimental drug study, we need to know what your mutation is. So when people call up all the time asking to be in a clinical study, the first question we ask, what mutation do you have? And if the answer is, I don't know, then we help you find out so that we can answer the question of whether or not we actually have a clinical study that will benefit you. Now, outside of OHSU, only about 10% of GIST patients, Life Raft, Michelle could verify this, that's still the right number? 8 to 10%. So 90 to 92% of GIST patients do not have this critical information for their doctors in order to make the best treatment decisions for them. So, this is critically important. Now, in terms of what to do about it, let's talk about things that don't work. So historically, what we've done to treat GIST back in the 90s or the 80s was to treat it like a sarcoma, which is a form of cancer. We give high-dose chemotherapy. It does not work. Less than 5% of people, maybe less than 1% of people benefit from chemotherapy. So we never do that anymore. It doesn't help you in any way. Sometimes we could consider radiation treatment, but it's hard to radiate lots of sites in the abdomen, and that's where GIST usually hangs out. And so radiation doesn't really work that well either. And so really, if you have tumor that's localized, we remove it with surgery. We'll talk more about that. If it can't be removed by surgery, we do something to inhibit what's going on in the cell. So our big solution, at least in the case of KIT mutant tumors, so here we have the KIT mutant protein. It's turned on. However, we can add a drug, imatinib or Gleevec, and now we have two other drugs we could use, and that inhibits the enzyme activity, which is the same as turning off the power supply. So we're just sort of ripping the battery out of the cell so that the cells cannot grow. And so this has tremendously impacted survival. So again, going back to the time when Mark was born in the 90s, if we treated you with chemotherapy, which didn't actually work, although we hadn't figured that out at the time, the average person with advanced GIST lived about 6 months. When we started doing our first clinical study in the year 2000 using imatinib or Gleevec to treat GIST, we immediately kicked up survival on average from 6 months to 5 years. That was sort of a different era because people had a lot more advanced disease because they kind of had accumulated from nothing else working. Nowadays, the average patient with advanced GIST has much smaller volume of disease, so we think that the average median survival starting on frontline Gleevec is around 7 years. I should say that this was our first study from the year 2000, so we still have patients from that study who are now 16 and a half years into their treatment who are still doing well, still on Gleevec. So we don't know what the upper limit is of how long treatment can be effective, because every day that they take the drug, they're setting sort of a new world record for themselves and for everybody else as well. So this is the diagram of how we treat GIST. So we're going to kind of walk through it step by step to sort of talk about all the sort of possibilities. So the first thing we'll talk about is primary localized disease, which is we found a GIST. It's in your stomach or your small bowel. It's not anywhere else. So what do we do? So if we can remove it, we remove it with surgery. And this can be curative, although the risk of recurrence is variable. So in some people, we remove a tumor and we perform a risk estimation, and Dr. Corliss will talk more about it. And we will say, you have a 2% chance or less that the tumor will come back. Don't worry about it. We'll do some scans. We're not going to treat you. You essentially have a 98% chance of being cured. Other patients have a much higher risk of recurrence, which could be 90 or 95 or closer to 100%. And those we are much more worried about recurrence, and then we do things after surgery, which we'll talk about, to prevent recurrence. But if we can remove it in one fell swoop, we will do so. Now, sometimes we see a patient, they just have one tumor, but we don't think we can remove it when we start. And so in that case, we do something that's called neo-adjuvant therapy. So neo-adjuvant means before surgery. So we're giving a medical treatment before surgery to shrink the tumor to the point where we think the surgery could be more successful. Now, most cases we don't need to do this because we can just remove the surgery. We can remove the tumor now and the surgery remains the same. But there are sort of some tricky locations where that's not possible. So one case is the duodenum, which is the first part of the small bowel after the stomach. It's kind of a tricky location. You got the stomach coming in, you've got the pancreas coming in, and you've got the bile duct coming in, and they're all in about that much space. And if the tumor is kind of in the wrong location there, or it's too big, then we have to take out the pancreas, take out your gallbladder, reconnect all the bile wiring, and rewire your stomach. So it's kind of a big operation. It's called a Whipple operation. If we can shrink your tumor with a pill and make it so we don't have to remove all those normal organs, we will try to do that. Another situation is when your tumor is in your rectum or very low in your colon, and we don't think we can remove it without causing the need for a colostomy, then we will treat patients with Gleevec to try to shrink their tumor to avoid the colostomy. Or there are situations in which the tumor is so big we don't think we can take it out because we don't even know how to plan the operation. So this is an example of that. So I guess I should use the pointer. So basically we're looking at the CT scan. So here's the liver. All of this is a ginormous gist. Okay. So this is the normal liver. This is the pelvis. This is the bladder being squashed. All of this is a ginormous tumor. So we can't do an operation on this because we don't even know what it's attached to or how we could lift it all out without having it fall apart. So in this person, rather than proceed with surgery, we elected to treat with Gleevec. So 6 months later, this is the current size of the tumor. Now you can see the bladder has re-expanded and all of the normal small intestine and stomach can sort of compete for space. So now we can figure out that this tumor is coming off one of these loops of small bowel, and we can do an operation with minor removal of normal organ tissue and without any risk of tumor rupture. So in some cases, if your tumor is not resectable, we can make it resectable by treating you. The next question is, after we do surgery, do we need to do anything else? And so that depends on how risky it is that your tumor is going to recur. So again, Dr. Corliss will talk more about it, but there's 4 things we think about. One is location. So the stomach is a better risk site than any place else in your abdomen. So everything else being equal, if it's in the stomach, it's less risky than if it's in your small bowel or anywhere else. Tumor size. As you might imagine, having a big tumor like I showed you is much more risky for recurrence than a 1 centimeter tumor, which has probably a less than 1% chance of recurrence. There's also something called the mitotic index, which Dr. Corliss will talk more about, but it's sort of a growth rate estimate of it. And finally, the tumor, if it ruptured spontaneously or ruptured during your surgery, which means it kind of spilled cells everywhere, then that's a high risk for recurrence. So there's different ways to do this, and Dr. Corliss shows a different way, which is a table. I kind of like this approach, which is if you're hiking, this is sort of like a topographical map, but instead of showing elevation, we're showing risk of recurrence. And the risk scale is down here, so sort of red hot means really high recurrence, and cold blue means not much chance of recurrence. And so we can look at where your tumor is, we can see whether it's ruptured, we can look at the size of the tumor and the mitotic index, and we can come up with an estimate of risk. So for some patients after surgery, if your risk is low, we'll not do anything but observation. If your risk is higher, and again, what does higher mean? That's sort of in the eye of the beholder, but generally above a 20 to 25% risk of recurrence, we would talk about taking Gleevec after surgery to prevent recurrence. So our knowledge of giving what's called adjuvant, which means after surgery, adding to surgery, is based on clinical studies, which were conducted. And this was a straightforward question. We previously had decided that giving Gleevec for 1 year was better than not giving it at all. This was a duration question. Is it better to take it for 3 years than it is to take it for 1 year? And so patients were part of a clinical study, and Tracy will talk a little bit more about clinical studies, but people sign up for it. You know, it's optional, it's not mandatory, and in this case, they're randomly assigned to either get standard treatment at that time, which was 1 year of treatment, versus 3 years of treatment, and then we looked at what happened. Now, it's important to remember not every GIST in the world was eligible for this study, so it's what I call the rule of 10. So if your tumor was bigger than 10 centimeters, or your mitotic index, which Dr. Corliss will describe further, was more than 10, or your tumor was more than 5 and your mitotic index was more than, should be 5, not 10. So 10, 10, or 5 plus 5 gives you 10. Any of those were high risk, and they were eligible for the study. Patients with smaller tumors or lower mitotic index were not eligible for the study because it was viewed that their risk of recurrence was low enough that you didn't need to do this, or if your tumor ruptured. And so this is looking at what happens to people after the study. So on the left is recurrence-free. So at the start, no one has cancer because they all had it removed, and we follow them over time. If your cancer recurs, then the curve goes down. So if it went to 0, that meant that everybody recurred. This is looking at 3 years versus 1 year. So you can see that the patients with 3 years had less recurrence. And if you look at survival, again, everybody's alive at the beginning. More people are alive kind of at every point in time, especially out 5 or 7 or 8 or 9 years later, if you took 3 years versus 1 year. So this is sort of our basis for thinking that for patients with high-risk tumors, after surgery, you should take Gleevec for 3 years. There's some thought, and we've done clinical studies looking at longer durations, 5 years or maybe even forever. We don't have any data from that. So currently, if you have a high-risk tumor, 3 years would be the standard therapy. So what if your tumor has spread? So now we're over on this part of the chart where you have what's called metastatic disease, tumor that spread. In that case, we would give you imatinib. Again, mutation, mutation, mutation. So depending on what type of mutation you have, you should take different doses. Most people should take the standard dose of imatinib of 400 milligrams per day. However, if you have the KIT exon 9 mutation shown in red, which is about 9 to 10% of patients with GIST, then you should take more Gleevec, 800 milligrams, because we know from systematic studies that people will do better to take the higher dose. So again, if your oncologist doesn't know your mutation and gives you 400 and you have an exon 9 because nobody tested for it, you're less likely to have a good outcome than if you were taking the correct dose. We'll say no. So again, this sort of emphasizes the point that here is a patient who had a very large tumor in their pelvis. Kind of everything you see that's not real white, which is the pelvic bone, is tumor. And after 6 months of Gleevec, there's a big response. But there's still a little bit of tumor left. So these are the cells that are hibernating potentially. Some of it's scar, some of it's hibernating. But this is the reason why you can't stop taking Gleevec. Because those cells will come back to life and it could grow and be as big as it was before. So, Gleevec can work for really long periods of time. For some patients that we have, they're 16 and a half years in and going. But unfortunately, in some people, the tumors can become resistant. So the tumors can start growing despite the fact that you're doing everything right, you're taking Gleevec, you have the right dose, but the tumor changes. And we call that resistance. So there's sort of two scenarios where that happens. One is if it happens right away, that's usually due to something about your tumor that we could know at the baseline. So it was a KIT exon 9, but we gave you the wrong dose. It was something called PDGFR D842V, which is not going to respond to Gleevec at all. And we have a clinical study of a new drug for that, but Gleevec is not going to work. Or you have wild-type GIST, which Dr. Corliss will talk about, but wild-type GIST is about 15 different types of things, and so a lot of them, or maybe most of them, won't respond to Gleevec. But what can happen in patients who have taken Gleevec for long periods of time, like years or even a decade, that you can have the tumor start growing again even though it has been controlled for a long period of time. And this is usually due to the fact that the tumor is mutated and you've got additional mutations. So this is the KIT protein, and you sometimes see these on pathology reports. And so what can happen is that additional mutations develop because the tumor can mutate. And remember, we saw the movie that the Gleevec had to wiggle in, so it's like a lock and a key. And some of you probably have heard me say this before in clinic. So that's how it works. But the tumor, when it mutates the protein, it changes the lock. The key won't go in no matter how much you take it. However, we have different kinds of keys that will fit in, and so we can switch drugs and overcome resistance. But these are the things that we're combating, which is not a infinite number of problems, but it's the same problems over and over that we battle with our drugs. So what do we do about it? Sometimes we increase the dose of Gleevec. That sometimes works. If it's only one spot, or we think we could remove the spots that are resistant, we remove them. We can go to a second-line treatment with sunitinib or Sutent. If that doesn't work, we can go to a third-line treatment with regorafenib or Stivarga. And again, it's all about the mutations. So even when we know what's going on with the mutations, Sutent, shown green, will work on these mutations, but not on these mutations. So again, it gets more complicated after Gleevec because not all the tumors we're battling are the same, and so sometimes we give a drug, and some tumors shrink, some tumors grow, and some tumors stay the same, and we're trying to balance out, do we think that the person overall is deriving benefit or not. After regorafenib, then there's no approved agent, so you really should be seeing a GIST expert, and the LifeRaf group can help with that, helping you find patient doctor lists or referrals, because the average oncologist probably has 0 to 2 GIST patients, and you never want to be in a situation where you're the only patient with a problem that your doctor's ever had or ever will see. So you want to be seen by someone who's expert. There's other things we can try, and we can battle your insurance companies or battle with patient assistance programs to try them. So these are approved drugs for other cancers that can sometimes benefit. Tracy will talk about the role of clinical studies, which is, you're in the land of the unknown, so oftentimes, you want to consider these clinical studies, and if you think about it, Gleevec was a clinical study at some point, and people had to sign up for that. Or we sometimes think about surgery if that's possible. So to summarize, GIST is diverse, mutation, mutation, mutation. We need to know what's going on in your tumor. After surgery, Gleevec can help. But if you have advanced GIST, the tumors can become resistant, and that is a problem. We have people in the back of the room and smart people around the world working on this problem, so we hope to do better, and we have clinical studies of some new drugs which are showing promise, and Tracy will talk about that. And again, thank you for your support, LifeRaf Group, for referrals, and also for financial support of our research and all of the patients who have participated in our clinical studies. Thank you. The world famous Dr. Corliss is going to now talk more about pathology and mutation testing.